Hey, Fix listeners. I want to take a minute to give you all an update on our DPO, Smile Now Dental Group. In case you haven't heard, we've been opening up locations all across the country for doctors just like yourselves. We started several offices this year to show proof of concept, and it's been off to the races ever since. So, if you're looking for an equitable partnership opportunity where you can have a profitable business that supports you doing full arch, I'd love to hear from you. We're looking to add several locations in the next year and want to offer the training and support necessary to make one of those yours. If you'd like to learn more, you can go ahead and hit me up on Instagram at Dr. Tyler J. Tolbert, or shoot me an email at tyler@smilenowdentalgroup.com and say hey. Now, without further ado, let's get back to the show. My name is Dr. Tyler Tolbert.
And I'm Dr. Soren Poppy,
And you're listening to the Fix Podcast.
your source for all things implant dentistry.
My name is Dr. Tyler Tolbert.
And I'm Dr. Soren Poppy.
Last week, you're listening to the Fix Podcast. Dr. Logan Locke, all about 3-on-6, and we are just continuing that conversation this week, getting into the nuts and bolts, exactly what is necessary, the skills and armamentarium needed to do cases like this, and how you too can become a provider. Hope you guys enjoy. Yeah, that's great. That's great. So in terms of, I'm kind of going back to the surgical approach and things. So a lot of these patients are still very dentate. They still have most of their teeth. I'm assuming that there's a tooth-borne guide that's going to maybe locate some pins that you can put in. Then you're doing the atraumatic extraction, and then there's a pin-retained or bone-retained guide that then will fully guide the 6 placement as well. And then is there anything else on top of that? I mean, that's just kind of a traditional fully guided approach, right? Or is there any other nuance there?
No, that's essentially what we're doing. We try and have everything tooth-borne if we can. Try and stay away from tissue-supported guides. Occasionally we have to hop on one of those. We'll have guides that help pin placement before we extract, and then the same pins go into the spots after we extract. Anything that we can do to get a stable guide is really necessary. All of the abutment placement is all pre-planned, so that we know we're not coming out of an embrasure. Obviously the wax up, everything is done prior to the patient stepping in the chair, so that we can immediately convert and screw in that prosthetic while they're asleep. So they're waking up with their single piece cross arch stability. We're getting all that right off the bat. But it's a thinner prosthetic, and so we really have to drive home the soft food diet, making sure they're not chomping on it, because that's something that can fracture. But materials are getting really awesome. They're the more and more we dive into this, the better the results we're getting because of the materials and the technology that's coming out.
Yeah, I'm curious too. So it kind of sounds like the initial surgical phase is almost indistinguishable from the typical FP1 that people see around, where it's guided, and usually there's like a scalloping guide for doing some, maybe not bone reduction, but plasty, I guess, just shaping things. Do you guys do some of that sometimes, or like what's really the difference between like a traditional full arch FP1 and a surgical 3-on-6, if that question makes sense?
Really, there should be no difference initially. The main thing is using a lab that basically this is all they do. And so we have trained our lab technicians in their designs to create pontic sites how we have found they work best. And because that initial prosthetic we have found is the key to everything developing thereafter. If you don't get an immediate prosthetic on, if you cover your implants and come in 3 months, it's all gone. You're losing it. And so that in order to maintain or create that architecture, we can do bone scalloping guides. I like to think of my prosthetic as kind of a negative bone reduction guide. So I don't generally use a scalloping guide, even in super gummy patients. Basically what we'll do is that the implants are already planned at the depth they're supposed to be. So let's say we have a really gummy smile. We know we're going to remove 3 or 4 millimeters of bone to get away from that. We'll plan the implants at depth. I'll put my MUAs on. I'll scan without having removed any bone. And then I will use the prosthetic, which is then designed with my wax up, so they know exactly how long my teeth should be. They know where the pontic sites should be. They're not referencing really the tissue data at all at that point.
Okay.
And then I'm going to, as I seat that prosthetic and get it to engage with the MUAs, I know where I need to remove bone in order to create those pontic sites. So the initial prosthetic we use as a kind of a negative bone reduction guide in that case.
Wow. Okay. So from what I picked up there, because earlier I was wondering about, we mentioned getting the prosthetic to be some distance from the bone, which is being left exposed to grow in that kg. And I'm like, well, how are you able to scan this? Because, in our workflows, we're always scanning soft tissue after.
Yeah.
How are you able to scan tissue versus bone, then plan this prosthetic? But that's not even a thing because it's already pre-planned.
It's pre-planned. So, we have to deal with zenith points and how tall are your centrals compared to your laterals and your canines. Are you getting them at the proper depth? Or the MUAs, getting them to where when I initially started doing these cases, almost always my laterals were longer than my centrals just because that's where I was placing my implants. And I wasn't thinking through these things through the design. So now that we have a lab trained, they can create basically, and you're using photogrammetry, you're scanning, but it's a bloody field. We're not suturing before we scan anything. So they're going to kind of blindly create these pontic sites. And now you're generally guiding them through this design as they call us during the surgery once they've got the design transferred and before we print it, and we can make any sort of adjustments we want if we know there's a piece of bone that's really high and we don't want to take it down and they've got the pontics too deep. All that kind of stuff can be changed during the surgery, but for the most part they're designing these cases in a way that aesthetically looks the best. And so really our bone reduction comes down to what does that prosthetic require in order to get that ideal spacing, that ideal tooth shape and size.
Yeah, no, that makes sense. So it's like aesthetics first, then prosthetics, and then eventually we're getting to play in the implant.
Yeah.
It's like the last thing that comes in the conversation.
Yeah.
Okay. Yeah. No, I mean, that's a beautiful workflow. I can really appreciate where that's coming from. That's awesome.
You might have mentioned this, but I just wanted to clarify. Are you guys, when you're using your guides, are you doing tooth-borne guides? Are you keeping a couple teeth? Okay.
Yeah, we generally try and do everything tooth-borne, and really those teeth become our when we take all of our scans, those teeth we leave during the whole scanning phase, so that they can merge the files from pre-surgery to post implant placement.
Do you have a preference on what teeth you're typically? So, like, let's say a patient comes in, right, and like you're a perfect case. I'm just curious what it would look like as far as what teeth are you leaving, what teeth are you removing, and then what you've mentioned a couple of times, but what teeth are you placing those implants into to get kind of that initial stability and that and good support for the tooth-borne guide.
Yeah, so I would say the majority of cases we are leaving. So implant positioning for us usually goes first molar / second premolar, where we're angling with the sinus, canines, laterals. That's generally our positioning for our implants. Okay. So that usually leaves some form of centrals that we can leave for the guide, and usually we can leave a premolar on each side. We try and get 3 points of stability, not only for the guide, but also for merging scans. So honestly, our designers know I will do whatever it takes to leave even a portion of a tooth in place for the surgery, because our scans, I don't like to place screws to align scans. I like to avoid those things if I can at all possible. And I like a really stable guide. So I'll cut a tooth in half and leave half the tooth for placement of the guide, and for future scanning, I'll do whatever I can to have that stability, because it means so much when you're dealing with, 0.5 millimeter for an embrasure space.
Yeah.
Hey guys, I just want to take a beat to talk about one of our sponsors, SIN 360, specifically their full arch digital workflow. Here at the Fix Podcast, we've been using SIN for about 2 years, and one of our favorite integrations from this workflow is the Micron Mapper. Photogrammetry is an absolutely pivotal technology that has changed the way full arch is being done. It's allowing us to capture implant scans in under 5 seconds with micron level accuracy that's beating any type of scannable verification jig or analog verification jig, what have you, and it's able to do it in under 5 seconds. And guys, SIN 360 is absolutely giving this thing away right now for $699 a month for 39 months with 0% financing. Think about that, $699 per month. That's about the cost of an analog conversion or fabricating an analog verification jig, or maybe even just a scannable verification jig. So I highly, highly, highly recommend you try this out. It's one of the most pivotal investments that you can make in a full arch, digitally capable practice. To learn more, visit sin360.us/thefixpodcast and get yourself a Micron mapper today. Oh, so in other words, some of the teeth would have to remain somewhat intact in order for the guide to stay seated while you're placing the implants. Is that correct?
Yeah. I'll leave as many teeth in as I can during surgery because that's what the guide's going to be seated on, and then I'll put all of my MUAs on. I use Micron Mapper for the most part now. We have an ICAM as well, but I'll place my scan bodies. We'll do our scans with those teeth still in, and then once I've got, we try and teach bottlenecks in surgery. It's a long surgery, no matter how you do it. Yeah. And so I'll leave all those the rest of the upper extractions till the very end after I've got my lower printing, and so we can get our biggest bottleneck, I should say, during the surgery is getting those scans into our lab so they can then get them back to us to print. So once that lowers printing, then we're finishing up. We're doing our final extractions. We're grafting or anything else that we need to at that point.
So is that to say that the approach is usually lowers first and then uppers?
No, I don't. Well, we have one of our providers that does, just because he hates tongue swelling up over the course of 4 or 5 hours. So we have Dr. Weisenberg, who's here with us. He does his lowers first for the most part. I'm just a creature of habit, and we used to do all of these. When we initially started doing them, we were freehanding them. We were doing cement retained. And so, I was relying on, I would mark up their face before they went to sleep. I'm trying to use a Fox plane and put my allotragus, and I'm trying to keep all these things because then I have a pre-made prosthetic. And I have to try and use my implant placement and get that prosthetic in the correct position. Cement retained during surgery was really, really hard, but it honestly, it makes for a good surgeon because you learn how to do all that stuff in the beginning. So, now with everything pre-planned and we can remove a lot of that difficulty from the providers. We can remove a lot of that necessary skill, I guess, because the lab is just can take all that information and they can put it into the prosthetic without you telling them to.
Yeah, that makes sense. And what kind of, I think you mentioned when you first started, you guys were using high-tech implants, and then you would switch eventually to Neodent CM. Mm-hmm. Is there like a particular system you guys recommend for this? What kind of nuances make it ideal?
Yeah, so we were using Neodent CM. I won't speak on Neodent CM because I have PTSD from Neodent CM.
You're not the only one.
So when we started seeing complications from that, we had a really well-known prosthodontist that was with us at kind of the beginnings when we were trying to make this trainable. Dr. Child, he's an awesome prosthodontist. We love having him, and he basically came on. He had a really good relationship with BioHorizons. He liked having multiple platforms, so we said, "Great, we're gonna switch over." So currently, we're using BioHorizons for all of our cases. We just switched to their new deep conical. We do see, that's one of the things I loved about Neodent. Those suckers can hold bone really, really well. We like the internal connection.
Of course.
But so the new BioHorizons deep conical has been good for us so far, and that's what we're currently using.
And why do you guys like being able to use different platforms? Because in general, like at least in the FP3 world, like people want a universal platform. It keeps their stock a lot easier. They can switch and swap. So what do you like about having different ones?
Well, and I without bashing Neodent, because I think I think GM is a great implant, and I think it's very similar to what we now use with BioHorizons. But we were having those stupid CM abutments were fracturing. And so really we wanted a wider platform for molar areas because we were worried about the strength of that platform. So now that, there's a lot of time behind GM, now with this deep conical with BioHorizons, I think the data's out there to support that it's, we're okay using those thinner platforms. BioHorizons does have two with their new deep conical versus GM's one. So I can get a little bit of a wider platform in the posterior, which I prefer. But that's kind of where that what drove us to a multi-platform was just seeing fractures in abutments in a CM.
Got it. And so in terms of, I always keep coming back to prosthetics, of course. So in terms of occlusal schemes, is there any way that people should be thinking about 3-on-6 versus an all-on-6 in terms of what you're looking to do occlusally?
For the most part, what we try and get canine guidance in all of our cases, solid posterior contact. If we're talking about, bite paper, I want it lightly dragging in the anterior, so we keep that too much pressure off of the vertices in the anterior. But just a solid occlusal, spread out contact in the posterior canine guidance.
Okay. And then I'm curious too about what are some of the big contraindications for doing a 3-on-6. Let's say you have like some really severe class correction or something like that. FP3 gives a whole lot of flexibility with regards to trying to correct a bite or jump a class 3 or something like that. Are you still able to accomplish that with 3-on-6, or does that kind of swing you a different way?
No, generally we can correct most of those things.
Awesome.
As far as contraindications, our biggest one is just, if they've already got severe bone loss, they've been in dentures for 10 to 20 years, then it becomes a little bit more complicated for most patients. We still do a lot of denture. We take a lot of denture patients into an FP1, but
really?
Most of the time if they've got really solid tissue and really good bone underneath, we can still do an FP1 on them. But that's our biggest contraindication. It's just bone loss to the point where now we can't fit 6 implants in, or it becomes too much to try and segment the thing. So, but otherwise, patients, for the most part, we're trying to get them in an FP1 if we can.
Yeah. On those patients that are denture to FP1, what are you guys freehanding those ones? Are you kind of like?
We'll do a tissue-borne guide. I always, when I train those, I tell all of our licensees to be cautious with it. So I train a couple techniques of how to use them to hopefully have them become as accurate as possible. But for me, I like to use them kind of as a pilot drill, and then I'll usually freehand after that.
Okay. Yeah, that makes sense. And how does the ponic shaping go when you're dealing with a fully edentulous case? Like, how do you end up getting all that scalloping and forming those pseudopapillae?
Yeah. So the main thing we take a lot of the tissue from the palate, and we're going to transfer it all to the buccal of the prosthetic. That's going to help us develop the good tissue there on the buccal. As far as the bone, like I said, I don't generally do a scalping guide. I will use, if needed, the prosthetic as a negative bone reduction guide if I need to create some. Usually it's like 8 and 9. I need to be longer than 7 and 10. So I'll usually try and create a little bit of a pocket for 8 and 9 to sit into, so that we get the correct zenith points. Because it does look funky if you've got 7 and 10 looking longer than 8 and 9 if they're smiling really big. So that's something. But honestly, you could do the case without removing the bone, and the prosthetic would just probably seat right against the bone on 8 and 9. And that's going to cause some resorption just in and of itself. It's going to remodel, and it's going to create the pontic site on its own.
Wow. No, that's great. Yeah. I mean, we just got back from the ICOI meeting in Orlando, and FP1 was like a really big conversation going on there. And that's a whole nother conversation for a different day. About the ICOI and what they teach versus what you mostly see domestically and things like that. But that was one thing that really did amaze me, is so many cases I looked at them, I was like, well, they have to do that FP3 because there just wasn't enough tooth. It wasn't enough architecture to create that tissue-borne. Not tissue-borne, but create all that scalloping and through a lot of patience and careful planning, they were able to do that, and I was really, really impressed. And there were just cases that I would you kind of alluded to this earlier. There are cases that I, with my FP3 trained eyes, would never think that you could approach from an FP1 perspective. But there are ways if you want to endeavor to do that.
Yeah, there's ways for most patients. I would say it's not everyone. It's not indicated for everyone, but there's a lot you can do to make these things look and feel really, really good. And it's a fun procedure to do. It's complicated, which I like. I like doing these hard little things, and so it's something I find a lot of joy in. And it kind of requires a little bit of everything. It requires, I tell guys all the time, go do your GBR courses, go do your tissue grafting courses. You got to get this stuff in because you're going to use it all. You kind of have to in order to do FP1.
Yeah, and I forgot to ask you. So the when you're talking about moving palatal tissue over to the buccal, is that usually like a VIP graft, like the vascularized interpositional pedicle, or is it like you're taking the whole thing full thickness?
I'll take the whole thing over.
Okay.
No, I'm going to take the whole thing over. I'm going to leave it bare underneath the prosthetic and bunch up the KG on the facial of the prosthetic and just let it fill in. Very nice.
Yeah,
I used to see.
It's similar to what we do with we'll do the same thing. Use a tissue punch to punch our multi units in, and then pull it in front of the tissue.
Yeah,
I think that's essentially kind of what you're doing, right?
Very similar to that. Yeah, and when I was taking my FP3 courses years ago, I remember seeing pictures of this guy. I can't remember what his name was, but he would essentially do these FP3s, and he would just leave the lower completely flapped, wouldn't suture anything, and he was like, "Look at all this awesome tissue I'm getting." It sounded painful, crazy.
I know Danny does that a little bit,
but you're essentially doing something like that to a lesser degree, because we still suture and tissue glue or whatever we want to do to keep that prosthetic, the tissue up against the prosthetic. But allowing that secondary intention for that tissue to creep in and get underneath the prosthetic, it can create some really good thick tissue.
Yeah. And I'm curious too, like following the surgery itself, typically, at least, everyone's a little bit different in how they like to do it, but in the FP3 world, people will have the procedure, maybe see the patient back the next day. Some will do 1 week. And then there's usually like a 3-week check to see how the soft tissue is doing. Maybe they move to a water pick or something like that, waiting 10 to 12 weeks and then taking new records and making a new FP3. How does that restorative process and sort of the post-operative process differ for a 3-on-6, if it does?
Yeah, it's fairly similar. So we, for the most part, we're seeing our patients 24 hours after surgery, basically just to dial in the bite, any aesthetic issues, and then we generally don't see them again for 3 months. So we, at that point, they call us if they need us. But like I said, most of our patients travel in from out of the country, so it's see them 24 hours after. They hop on a plane, they fly back to their homes, and we see them in 3 months, where we will redo our scans, take our tissue data, and tighten up anything that we need to, make all of our aesthetic adjustments. We make them a second set of temporaries, and we can do second temps and finals here at this office because we are close to the lab. We can have that done within 7 days.
Nice.
But otherwise, if they're close, I try and have them stay in their second temps for a couple weeks to try them out.
Yeah.
So they basically are flying in 3 times. Is that correct?
Twice. Well, sometimes it's 3 times. Yeah, a lot of times people bring their families out for their week-long appointment. They'll make it a vacation. They'll come skiing. They'll visit Utah and make it fun. And so we can seat their finals within that same visit. Otherwise, they get their second temps. They fly home. They fly back in whenever we decide they're ready to go with their finals.
Okay. Got it. Okay. Yeah. That makes sense. And I'm curious too, and maybe we haven't been doing this long enough for you to see this, but have you ever had a patient that received a 3-on-6 and due to whatever circumstances then had to change to an all-in-X? And if so, what's kind of been their feedback about what they think in terms of how everything feels and the maintenance of it? Like what's been kind of the feedback you've seen there?
I haven't had to transition anyone yet to an all-on-X.
That's good.
Most of our, I'm trying to think if there's anyone that has come through that's even close to that yet. I don't think so. I mean, honestly, it's a little bit of an exposed abutment is about as bad as we're seeing currently. Okay. Obviously, you're going to have you can get some implant failures and stuff, but we can work around them. So I haven't had to transition anyone yet. I did just transition someone, went down to Cancun, got an FP3. Actually, it was fairly well done. They didn't remove enough bone, in my opinion, for the FP3, which worked in my favor. He came back, he hated it. And so within 3 weeks, we transitioned him from an FP3 to an FP1. Okay. That was last month, I believe. Cool guy. But I haven't had to transition anyone yet. But I assume at some point we probably will. I mean, I think 20 years from now, we might be saying something different, and we're ready to do that if need be. But I think we bought these patients a lot of time.
Yeah. And are you able to do a decent amount of lower 3-on-6s, or is this almost mostly uppers? Or if you are doing lowers, what are some of the nuances there that make that possible? Because I know that can be challenging.
We're still doing it. We do a lot, equally as much on the lower,
right. Okay.
Because a lot of times that the teeth are shorter, you generally need a larger prosthetic space. You generally need more bone reduction in order to get a thicker prosthetic. For us, I can have 6 millimeters of restorative space and I'm good. I'm not seeing fractures. Honestly, our fracture rate with these zirconia implants is close to zero. Like if you segment and you're getting, 3 to 4 unit bridges, the zirconia does not break. It's really, really strong. Now, if you're getting longer span bridges, then you can see some fracture over time. But even on the lower with minimal restorative space, we've got really strong prosthetics.
So it seems like there's kind of an inverse mentality. So like when you first do the surgery, we're more concerned about the cross arch stability and making sure the implants integrate. So we need everything to be connected. But once those are healed and we go to the prosthetic phase, everything changes. Now we want them all segmented, and that's going to be better support for the actual zirconia prosthesis long term.
Yeah,
is that a correct assessment?
Better support for the prosthetic, easier to clean. I mean, they can floss in between the bridges.
Yeah,
that's one of the main things we talk about is how, if we're talking about hygiene, we've done a lot of measurements just on our own FP3s versus our standard 3-on-6. You're taking the position, basically the area that's going to build up food and debris. You're taking that from an FP3, which is fairly hidden up there, harder for them to access, and you're bringing it down to the tissue level. So generally, they can see if they've got crap piled up on their teeth, they're going to be able to see it. Your prosthetic to tissue contact, if we're looking at thickness of how much space can gather stuff. So let's say in an FP3, your average is, because as you go down, our bone is a triangle. So as we go down on that triangle, we're getting wider and a wider area to pack stuff, and that prosthetic on an FP3 can be fairly thick. Ours, we're getting small pontic sites, so the area where they can pack food and debris is much smaller. It's more visible. They can floss in between bridges. They can floss under them super easy, water pick. Hygiene on these things is just night and day over what we've seen in our own FP3 cases. I mean, we don't remove them once a year.
I was just about to say.
We want to, there's whether or not the research is good that the tissue can adapt and adhere to the zirconia. We don't want to, most of the time, mess with any of that, any of our papilla that we've developed over years. We want to leave it in there in place. And so we don't remove our prosthetics. They're easy to clean with just a regular cleaning. Our hygienists have no issue doing that. We're getting a lot less underneath these bridges than even our own FP3 cases, which we feel like we do a good job with our FP3s. But, suckers are hard to clean.
Yeah, I love those posts when you take off like an FP1 or a single crown or whatever, and it's got that ultra polished zirconia, and they're taking it off, and it just takes tissue with it because it literally just actually formed a biological seal, which is crazy. Yeah. But also, I'm curious too. So the screws that you guys are using to retain these, is it just like the typical like a desk screw, or are we using like Powerball, Vortex, whatever?
We have some guys using Vortex. We use DES almost exclusively right now. Okay. Really, our long-term goal, everything is made for FP3 currently. It's all multi-units. Everything is FP3. And there is a lot that we could do with stuff that was created specifically for FP1. We would love to have a wider and a longer prosthetic screw that was actually designed for a direct-to-connection. Most of these screws are still designed for titanium copings. So, and the MUAs are designed for FP3, which has a ton of variance in angulation. Because we're going between 2 units or 2 implants, we don't have a ton of degrees of variation. We could have a longer MUA that would allow a much more stable prosthetic over time. So, there are a lot of things that we're working on to hopefully advance FP1 and get those parts and those materials that I think would benefit patients long term. And I think we're seeing a lot more FP1 come around. When we first started doing this, you had guys doing it, but they were kind of off in the distance and you wouldn't hear about them. Now there's more FP1 courses since we started doing this. There's more talk of FP1. I think it's coming back around to where you'll see more and more guys doing it, which I think is good. But I think we need the implant companies to step up and start creating parts that adapt with the technology of where it is today, and give us stuff that we can use that address some of the challenges with FP1.
Yeah, we definitely, like Tyler was saying earlier, we definitely saw it a ton at the conference that we were at, almost to the point of going the opposite direction with FP3 and recommending FP1 on a lot of cases. What would I think this is something that like our listeners always love to just hear from whoever we have on the podcast, but do you have any particular CE that you love, maybe any recommendations for books learning this material? A lot of our listeners are people who aren't doing full arch and they want to get into it, right? So if you have a couple good books, a couple good courses, I know you guys obviously have a course, but it sounds like before somebody comes to your course, it's probably good to get a good idea of like doing full arch, doing surgery and stuff like that.
Yeah, for sure. Most of I have a lot of dentists that reach out to me fresh out of school. I send most of them to Implant Pathway. It seems like they do a great job as far as getting guys going. I love, I'm gonna forget their names, but they're 2 guys that I kind of just started following through Instagram. Dr. Matthew Feen and Israel. He's out of DC. DC Implants is his Instagram handle. They have a set of GBR courses and tissue grafting courses that they're the favorite courses I've ever done.
Really?
Tons of good experience, and I think they really catapulted me into doing more of this and feeling more confident that I could build bone and build tissue and do that kind of stuff. So their courses, I can't remember what their group is called. But
we'll try to add it to the show notes. We'll figure it out and try to add it.
I'll look it up. But those guys are awesome, and they're posting amazing cases on Instagram. A lot of single units, and I try and look at what guys are doing for a single unit. Someone loses number 8, and Israel, that dude, man, he can make it look like they never lost a dang thing with the way he develops tissue and his implant placement. Everything that he does looks so awesome. So I try and take what he's done and anything that we can do to incorporate that into our FP1, because we're essentially just trying to do that at a larger scale. So these guys that are really leading the field in implant dentistry and in tissue, these are 2 periodontists, and we try and incorporate that stuff into what we teach.
Okay, great. Yeah, we'll try to add those to the show notes, and those are excellent. Just talking about that, it kind of goes into a new fixation that I've been having as far as, we do, like I said, a lot of all-on-4 stuff and a lot of immediate load. And I feel like it's pretty straightforward once you kind of get that down.
Yeah.
And now I'm trying to figure out, I'm getting more into like just immediate loaded singles, immediate loaded bridges, really like trying to manipulate the tissue properly so we can do these cases with a predictable result and without having to put a patient in like a flipper for 3 months and then come back, have to like try to figure out how to get the tissue to stay where you want it. And it's not always possible, right? Because I feel like it's much harder to get good torque on your implants when you're just doing like one tooth or even a bridge versus when you have a clean slate and you have multiple places to place them. But what are you guys doing in your office as far as like single implant goes? And like, are you immediately loading those? Are you printing them onto a tie base? Like, how are you guys doing that?
Yeah, we've done quite a few recently where I'll put an MUA on and have our lab quickly design some form of tissue shaper
on a single.
Yeah, on a single.
Nice.
Then eventually I'll take the MUA, because with the MUA I can use photogrammetry, and which is a huge benefit, and I can have them create whatever I want from there. But I've done as much as using I cut off the fingertip of a glove and stick an old abutment that I had sterilized. I stick that through and push some composite into it and shape it myself to create tissue healers. I don't do in the anterior front four. I'll immediately load it without any issue, keeping it out of occlusion. Beyond that, I still don't immediately load single units. But
are you and the front four? I mean, I think the front four are the ones that are the most important that I'm kind of referencing, because those are the ones that patients don't want to be wearing a flipper for, and usually I don't know, the flippers never look like amazing up there because you kind of have So are you typically always doing so? And it's funny because I actually have a case coming up, and I was thinking about doing just that, doing like putting a multi-unit on, and trying to print a crown right to that multi-unit. I did a case last week where it was 7 to 10. We did a direct to multi-unit bridge, and it worked awesome. It looked so good after, and I was really, really happy.
You just did a third of a 3-on-6, dude. You're
in.
He's almost there. He's going to be a licensee in no time.
You're already there. You might as well sign up.
Now, maybe we will. But what?
Okay, go ahead.
Oh, I just want to finish a thought. So, when you aren't doing printed to multi on those anteriors, how are you doing them? Are you doing printed to tie base? Are you kind of designing the crown yourself for those single anteriors?
For the most part, I've done a lot where I will use their own natural tooth. If I'm just taking it out, which is generally the case, right? We're trying to keep and preserve everything. I'll use just a regular, just a tie base or something like that. And I will cut everything but the facial off of the tooth, and I'll, create the shell, and then I'll pick it up that way, take it off, unscrew it, shape it with flowable or whatever I need to do, polish it up really, really good, and then go with that. I know there's Israel Puderman, same guy. Hopefully I didn't botch his name. That runs these courses. His Instagram, he's got some specific printable tissue healers that I think look pretty awesome. And I can't remember where he gets his from, but I've thought about starting to do kind of exactly what he's doing, because he gets some crazy results. But I like creating my own. That's generally what I've done, just using whatever they've already had in there and create a shell, and then get the correct form coming out of the implant so that it develops that tissue. And we've got a lot of experience in doing that, so that helps.
Yeah, great. And I may have misunderstood you a moment ago. So when you're doing like that anterior single, and you mentioned using photogrammetry, so you put the MUA on there, then you put your micron mapper scan body on there, you take your micron mapper, and then that's how you're printing out a temp. When you go to finalize that, are you then using that data to swap to fixture level, or do you just keep it all MUA?
No, at that point you're getting rotation on the crown, right? So doesn't work for a permanent super well. If it's out of occlusion, you can usually keep it from rotating, or you can sometimes bond it to teeth on either side or create something so it won't rotate. But I generally would just do that for an initial tissue healing type of situation.
Tissue former. Okay.
Yeah, tissue former. Then I'd put my scan body or my impression coping on, get a bunch of light body in there so it captures what I've already created, and then get a screw retained crown with a custom abutment put in.
Cool. Yeah. Yeah. So we've talked a lot about, what's kind of taken you from, pre 3-on-6 to now. And now I'm kind of curious about, where do you see this being in, 10 years? What are you mentioned a moment ago, like long-term goals? Like, where do you kind of see this concept going? Where is the innovation going to be at, if you see any room for that?
Yeah, I think the innovation will come, and we're pushing BioHorizons. We're pushing implant companies to help us create things that are more geared towards FP1. Like I said, we want to. Right. There's so much technology right now. There's so much that we could be doing to make these cases easier and more predictable. We just need these guys to come along and make the parts for it. So hopefully that's where the innovation comes. We are continuing to just make our processes streamlined as we possibly can. We want more guys doing it. We want patients to have options to preserve their bone long term. We think it's the correct thing to do. And so ideally we get as many doctors providing 3-on-6 as we possibly can. Nice. I think that's what our long-term goal is. Obviously we want that financially, but it also, I would say 99% of patients that are going through full arch still have no idea that FP1 might be an option for them. Yeah. They just don't know that it exists. And so it's only those that hop on Google and start to search for other options that really end up with us. So I think if once we can get to the point where patients are informed that there are options, then it's going to drive more and more doctors into learning how to provide FP1 for their patients. And whether that's with us or doing it on their own, I think it's good for dentistry to have more doctors doing what we're doing.
Yeah, no, I totally agree. I mean, there was a time when, people were just doing one implant per tooth and doing all kinds of crazy grafting and these hugely staged approaches over years and years and years. And then all in X, or really just all in 4 at the time, kind of saved the day with that. And nobody knew about it. And then once people knew about it, there was this massive, massive wave. And now, patients have general awareness around that, and they go around shopping for the best prices or the best processes or whatever to get it done. And it seems like you're kind of, in this early phase of that 3-on-6 awareness is starting to happen. Providers are starting to pop up in places. People are having more options. And, before you know it, this is going to be this, I mean, we may already be there, but this is becoming this really emergent thing. And that's what patients are looking for, because they do want that conservatism, especially if you're younger than, 35, 40, you do kind of probably want to be looking that way, because, an FP3 is probably not going to die with you.
No, we know these things probably won't. We hope they do. We hope that what we do is will last as long as possible. But I think giving someone longevity and options as they move forward, I think is important. And it's been kind of a weird process. Just a week or two ago, these YouTube videos start popping up on with 3-on-6 and why it's awful and it's a cult, and it's really weird stuff. And it's weird seeing something that has been so small, and it's been something that we just kind of made here in Utah, and a name that, I mean, we didn't make FP1, we just made this little 3-on-6 thing. And now to start see it pop up on insurance forums and on other doctors' YouTube videos. Awesome. And it's been a funny thing to see happen in the last couple of years, but it's I guess it means we're doing something right.
Yeah, well, I mean, I think it's really cool. And, I think we feel particularly fortunate to be talking to the pioneer of 3-on-6 on our podcast. So maybe, once it becomes this big popular thing and people are doing the research, they'll go and find our podcast and they'll get to learn about the beginnings of it.
Yeah. Hopefully some guys get interested and want to come out and hang out with us. And I think it's fun. I think our course is awesome. We have a Teams chat with all of our providers, and everyone's just posting cases and questions. And I generally stay away from dental forums because I think dentists are jerks that can't just,
can't get
they
along.
have to nitpick every little thing that someone else does. So I tend to stay away from those, but we've got a really good forum of awesome providers, awesome docs. That's been one of the most fun things for me. I'm not a super well-spoken person, so getting into this training role where we're teaching doctors how to do this and traveling out and meeting their staff, it's been super fun to just meet a lot of like-minded doctors and get to know them and develop friendships with them and be able to, I have a guy down in Florida that's, in my mind, just an awesome FP3 provider, and places like you guys, he's doing pterygoids and everything, and I love having someone that I can run some stuff off of. And and then I've got a guy that switched from just doing wisdom teeth in Vegas. He decided he was done with wisdom teeth and he just wanted to do FP1. So he's just a 3-on-6 provider in Vegas. And
nice.
So being able to meet him, and when I have Wizzies I need to do, I'm texting him, what the heck, what am I doing? So it's been a fun thing to get to know doctors and be in a situation like this and meet you guys. It's fun
for sure.
Well, hey, we're honored as well. And what can people do if they are interested in your course, or they're interested in getting into the 3-on-6? What's the best way that they can reach out to you? You said the other doctor, was it Peyton, or what's the other doctor's name?
Randy Roberts.
Randy Roberts.
I'm sorry.
Micah Weisenberg, he helps me run the course. And then Randy Roberts, he's the one that started this whole thing. And he's kind of leading our R&D and what we develop as far as progress moving forward.
Cool. Nice. So how would people reach out to kind of get involved, get over to your course, and start doing the 3-on-6?
Yeah, if you want to, so 3on6.com, our trainings should be on there. My Instagram, I try and post a lot of what I call tissue porn, just really good scalp tissue. I like to post that kind of stuff. So if you want to see kind of what we're doing, my Instagram is doc.locke. That's L-O-C-K-E. And they can message me there. They can text me. My number's 801-755-9243, and you're welcome to text me. I'm happy to send you. Whenever I talk to guys and they're questioning whether or not they want to come, I just go through my camera roll and find my most recent cases and shoot them over and say, this is what you can do. Like, this is what we're pushing out. And I think for the most part, it helps them gain the confidence to come on out. So welcome to text me, and I'll shoot over some cases so you can see what we're doing, and or message me on Instagram. That's good too.
Awesome. Well, we really appreciate you coming on, Dr. Locke. This was a huge learning experience for Dr. Poppy and I. And, I'm really excited about what you're doing. I think you've made a massive contribution to the full arch world. And, we always talk about, how to be conservative in an FP3 case, right? Like trying to preserve bone or do a more conservative technique here and there to keep people out of zygomatics. And you've created this whole new intermediary phase between that, the natural dentition to the FP1 and then of course the FP2, FP3. And, I think the beauty of it is we're getting to the point where we can really support people throughout their entire life cycle and, keep them in teeth that don't have to come in and out, as long as possible. And I think it's a really valuable thing. I love that you've really democratized what you're doing and made it very approachable for other providers. It'd be very easy to be a lot more, cagey about that kind of thing. So I definitely appreciate that. I think your heart's in the right place, and I feel so privileged that you came on our show.
I appreciate it, guys. You guys are awesome. It's been fun to get to know you, and hopefully we get to do more of this.
Yes, sir. You got it. Well, until next time. Thank you.
All right. Thanks, guys.